Hello. So we just kind of finished a little bit on the personality stuff. And I know that over the last week or so, you've been reading background on personality assessment, psychological assessment in general, but personality assessment. We talked a little bit about the Rorschach and the TAT. You guys have been doing some stuff with the MMPI, but the MMPI really is, in a lot of ways, a foundational tool for diagnostic or assessment psychology. So what I want to do is I want to give you a little bit of information about it, because ultimately where I want to kind of segue into is the value it has for understanding, defining, and predicting, again, because psychology at this point in time as a science is really focused less on understanding of how you became that way and more on what does the way you're acting today reflect on the way that you resolve whatever it is that got you there, and then in relation to, so then what should be the anticipated behaviors in the future in similar situations and more ambiguous situations. So let's look at this real quick. This is essentially a profile. This is the sheet for the MMPI, and this is the adolescent one. But it's very, very similar. And so one of the things that we see referenced a lot of times is people talk about faking good, faking bad, understanding, and the reality is you can go online right now and you could literally take this test online for free. Even though it has great value, it's not hard to cheat on any of these tests. I mean, if you know that, let's say from a forensic capacity, you know that you've been arrested for domestic violence, and I'm doing this evaluation on you, you have, even average intelligence is going to tell you whatever you do, don't support or endorse, and certainly don't suggest any kind of aggressive tendency. Don't talk about someone being weaker or needing to be controlled, or, it's not that hard to kind of figure out what is the testing looking like or looking for. So anyways, the MMPI is referenced in pretty much almost all situations where you're going to see a psychological battery that answering questions about competency, answering questions about personality, clinical questions about driving therapy. Not always when you're looking at like custody of a child, you might bring this in. I've had a couple where I've had to do them because one of the individuals that was being evaluated one of the individuals that was in a custody battle had a history of mental illness, and I had to try to substantiate how much that disability or disorder impacted their potential to make sure that the child's well-being was primary motivation. So anyways, there's a lot of ways that you can fake. So what you see on the front end of this thing are what called validity scales. There are four, really I say there's six, but there's 4 or 5 validity scales that have one purpose. They're trying to determine someone that's trying to look favorable. And so the whole way that this instrument is standardized is to provide questions that if someone wants to look favorable, that's the way they're going to endorse those questions. It's one of the reasons that the MMPI, more than most of these personality assessments, doesn't do something like never, sometimes, often, always. They say true or false, because they really want you to take a stance on, even though sometimes I like science magazines, the majority of the time I don't. So if it says I like science magazines, you'd say true or false based on who you are. Now, even though you say sometimes I do, sometimes I don't, you make a definitive answer, and that definitive answer, it can be false, like you can literally be trying to create an impression, but in general, the way that you respond is going to, again, shape a theme that then results in specific scores on these scales. So there's multiple validity scales that endorse trying to look favorable. At the same time, and remember, I do a lot of forensic stuff, there's also some that endorse looking unfavorable. Now you might ask, why would someone ever want to look unfavorable? if you're trying to determine that you're significantly impaired intellectually, psychologically, especially around like a depression or bipolar, and your judgment is so impaired because you're in a hypermanic state, and you might feel that when there's questions that endorse poor judgment, you literally suggest that, yeah, you know what, I'm always doing things that people get mad at, or I'm always doing things I regret later, or because you're wanting the court to see someone that's significantly impaired because you don't want to look competent. You don't want to look sane, per se. I've even, and it doesn't happen too often, although I always hear in dialogues in some of the trainings that I do, individuals that they don't want to pay child support. So if they're impaired enough on a profile, then there can't be anything that substantiates that their capacity for gainful employment and income should then support alimony or maintenance or child support kind of thing. So anyways, at the crux of the MMPI is what's called the validity scales. There's a lie scale, there's favorable scales, there's validity scales. Do they respond the same way? Reliability scales, do they answer the same way on 4 or 5 questions? If you've had any exposure to the MMPI, you realize that in over 300 and something questions, and the MMPI-A is a little bit shorter than the MMPI-2, but one of the things that they do is they give you every theme at least 5 times, with the idea being that they want to see consistency, as well as they want to see where maybe you start losing some of your objectivity or your control. Like, there are even questions on here that might trigger you. One of them being, my parents are always right, or I never tell a lie to my parents. It might seem like a very simple thing, but when you think about 3, 4, 5, 600 questions, 1,000 questions over a battery of tests, you start wearing down some of that mental fortitude, some of that regulatory body, some of those coping mechanisms or defense mechanisms, and the individual starts to, although it's objective, they still start to kind of contaminate and leak a little bit. So there's lots of validity stuff on these tests. But then when we start actually looking at the core of the test, these are called the content scales. Now, there's a lot of them, but what's interesting is they focus specifically on a lot of attributes that we would say, even though, like an IQ test, let me step back for a second. Like an IQ test, we can look at IQ as this fundamental premise of how we reason, we problem solve, we make sense of things, we adapt, we use our memory, we use attention, we use processing speed. It's a variety of skills. But the reality is, intelligence is something you do. And it's the way you do it and how effectively you do it. It's not one individual skill, it's a series of skills that are simultaneously utilized. The same thing can be said for this. So the MMPI, it's going to look at individual scales. It's going to look at hypochondriacal, like a lot of the physical complaints that go along with stress and anger. It's going to look at depression. It's going to look at hysteria. It's going to look at psychopathic deviance. It even looks at masculine femininity, because sometimes at the core of a pathology is a struggle with identity or the idea that there's gender roles. You're looking at paranoia. You're looking at schizophrenia, hypomania, social introversion. There are so many content scales that look at what we consider to be the core functionality of personality. And so what we're trying to find is, where are the places, and remember, individuals that come in for these evals, unless they're court ordered, they're usually self-referred, or they're doing it in conjunction with therapy. So they're not really motivated to lie on the test unless there's an additional agenda to it. But the reality is, you can take a lot of what you're getting with some value that it's going to then lend itself or contribute to a more comprehensive psychological profile. But what gets lost a lot of times is we see this profile and you say, okay, so how does this become a diagnostic entity? So there's an elevated scale, and let's say it's the depression scale, and that's elevated. So they're depressed? No, that's not how it works. In fact, what's interesting is we look at what's called composite profiles. And so what a composite profile is it's when we take the 2 or 3 peaks, the things that are being endorsed the most on the test. So you can see, let's see if we can pull one of these off. Cool. Okay, so we've got depression and we've got hypomania. Those 2 are elevated. Okay, those are the 2 highest peaks on this scale. And so you take that profile and you see that there are some consistent personality attributes or characteristics that are prevalent. I don't want to say synonymous, but are prevalent with individuals that have that kind of an elevation. Self-centered, narcissistic, ruminate about self-worth, they're anxious, they're tense, they have a lot of somatic complaints, they tend to use alcohol as an excuse or an escape from stress. There's a lot of information that when you have that profile endorsed, that it suggests. Or we could look at 3, 4. Again, another. So you got deviance being looked at, you got hysteria looked at, and so individuals with that elevation, they have intense anger, they tend to keep score. If 4 is higher than 3, by at least 5 points. I mean, look at the number. And the reason we can do this, the reason we can pull off, if there's a 5-point difference or discrepancy or gap between 2 scores, what's the significance, the clinical or the psychological significance? It's because we have tens of millions of individuals that have been administered this test that you can start standardizing and finding the consistent patterns. And there's enough individuals, and this is a funny number that I'm going to say, but in a lot of psychological contexts, the value of an instrument is usually when it's around 67% accurate. So what's interesting is if you go back to the IQ test, when you see that bell-shaped curve, the average range of 85 to 115, 67.5% of people fall between that range. So we call the average usually represents about 67.5% of the population, whatever population you're testing. Same content or same concept behind the way that they profile with the MMPI in particular. And so there's this barrage of information that we've gotten over tens of millions of people being administered where you start finding patterns. Now, are they absolute patterns? They don't have to be. I don't need there to be a 1 correlation to say that there's enough evidence in this assessment to say that there's anger, there's unresolved resentment, there's difficulties with reality testing, there's heightened paranoia that influences judgment. I don't have to have it be absolute to say that it's representative enough that it's interfering, and that's the key word, guys. It's interfering with everyday functioning, because that's ultimately what makes it pathological. Having hallucinations does not make you pathological. Having hallucinations that prevent you from getting out of the house because it stresses you so much that the world is going to attack you, or you're seeing things, or there's spiders crawling so much that you're tearing your skin away, that's when it becomes pathological. It has to interfere with your everyday functioning to truly be pathological. Now, there are situations where it might interfere with other people's functioning, but ultimately what we're looking for is, what is it about the way that you're psychologically regulating that's not effective enough that results in you getting referred for a psychological assessment? So the MMPI in particular does this great job of having all these profiles endorsed, and there's probably about 400. In fact, what's interesting is, these are 2-number profiles. When you start looking at like vocational stuff, when I look at a FBI agent, there was a period of time when I was doing some stuff with Quantico, the FBI Academy in Quantico, and part of it was behavioral profiling. Now, it started with offender profiling, and then we segued into cadet profiling. And so one of the things that we saw with the MMPI is there's a four scale profile of elevation that's fairly consistent with individuals that are successful as FBI agents or field agents. In fact, there's times when someone applies for the FBI, we do this comprehensive evaluation, and from the results we suggest that they don't do field work, they do analytics. Or linguistics. So we can make references based on the way that their profile comes across, IQ as well as personality, and neurological, because sometimes there can be a neurological component. But ultimately, we look at the value of the consistency of the way someone manifests, the personality structure, that ego structure of the individual, and then you can literally start making some kind of like extrapolate that information in a way that it then gets applied to law enforcement, military, definitely FBI. You can look at it in terms of a profile for someone that's trying to be a teacher. You can look at a profile for someone that's trying to be a doctor, a lawyer, and you can use the MMPI, not alone. Again, just like the Rorschach. None of these tests should be used individually. You have to have collaborating evidence, and that's probably one of the most important parts that needs to be addressed, because a lot of you guys bring up great points about the test can't be used to really define who we are because we're unique. But if I do an IQ test, if I do a mental status test, if I do a projective test, if I do an objective test, if I do some type of neurological thing, if I do something adaptive, I think I've probably addressed a lot of the stuff that encompasses what you would call your me. Your cognitive functioning, your emotional functioning, your kinesthetic functioning, your executive functioning, your psychological functioning. So I don't ever have to say I know who you are. I can say with a sense of certainty that when the profile has been done in a way that the battery is a valid battery, because we don't have opposing forces trying to invalidate it. I have an individual that's trying to look retarded because of the resources they have, as well as they get on disability and don't have to work. But we're going to use this under the context of, we're not talking about people that are trying to get away with something. We're talking about people that have a vested interest in the profile. And so when we think about the MMPI in particular, I mean, listen to this, and I'm going to read from it because there's no way that with this limited old man memory I'm going to remember them all. But we, as a side reference point for what you pull from the MMPI, I'm just going to rattle off all the scales in addition to the content scales that also show endorsement. And you'll see how they're relevant or how they relate to a lot of different ways that we're going to try to determine what do we do with the information. Whether it's a clinical intervention, a resource allocation intervention, a criminal justice intervention. But you got anxiety, you got fears, you got obsessiveness, you got depressiveness, you got health concerns, bizarre motivations, anger, cynicism, antisocial personality, type A personality, low self-esteem, social discomfort, family problems, work interference, negative treatment indicators, which are kind of interesting. That goes along with antisocial and narcissism, but you'll find some people that a lot of their energy goes into sabotaging you so that you can't prove that you can understand them, kind of thing. More aggressive stuff, psychocism, which is essentially, it's psychopathology, but really it lends itself also to how bizarre do you want to present. Because some people like when people are afraid of them. We've got the alcoholism scales, the addiction scales. So within the MMPI, there is so much information we pull out that then we look at a Rorschach, we look at a TAT, we look at, there are other objective tests, the adolescent psychopathology test, the Milan clinical access test, or MCMI. There's a lot of other tests that we look at that can kind of collaborate and develop this profile, because ultimately, especially if I end up on the stand and I'm testifying, I want, with a great amount of certainty, to describe the person that's in front of me or that was in front of me during this evaluation, because I know the implications of my recommendation, or even the implication of my presentation of how their pathology impacts their ability to be accountable for a crime, or even, unfortunately, I mean, and this really is unfortunate, but there are also times when you do an evaluation to determine the extent of damage, which correlates to the amount of, like a financial settlement in a civil case, civil damages case. So there's a lot of places where assessment really comes into play, and it can be used willy-nilly. It can be abused for sure. Ultimately, my job as a professor is to, this is an undergrad class, so it's really exposing you to assessment, but I teach at the doctoral level and I teach at the recertification level, which is after you're a doctor. You can take some of these classes to learn specifics around neuropsych, or around, specific around forensics. I do some of those classes. So I put a lot of value in the scientific or empirical strength of these assessment instruments, because I really do believe, and I've seen in my experience, not just personal experience, but also professional experience, that more comes from the evaluation that benefits than damages. Because there's no doubt there are times when you do an evaluation and the outcome is not a good outcome for somebody. Whether it's the victim, so you can imagine you have someone that was, and I'm going to kind of segue into neuro, but you can imagine you have an individual who's sitting in front of you and you're evaluating, and you can see some marked deficits, and this is a post-injury. So they got hit by a car, or they got hit by something, or they had a stroke, whatever it is. There was some incident, there was some infarct that caused what we call brain or spinal injury, and from that they're in front of me because of the referral question can be very diverse, but we'll imagine that the question is, this is an individual that's suing a company for potential earning damage, with the idea being that they were hurt on the job, or they were hurt in a fashion that now they can't do their job, and what should they be entitled to? And so there are times, and not often, it's not the norm, that you have baseline data prior to the injury that you can then compare. But there are times when someone might have been evaluated in high school, or as part of qualifying for Mensa, or maybe even they were arrested and there was an MMPI done because they were drinking and they were abusive towards the police officer, so they had to go through a psychological eval. Whatever it is, there was pre-injury data or profile that was generated. And from that, now I have them in front of me post-injury, and I'm having to determine what is the extent of the damage. Now, I don't know how to say how much damage they've experienced, because I most of the time don't know how they used to function prior to the damage. So you have a doctor who is a cardiothoracic surgeon, top of the game. If you know much about medicine, cardiothoracics is essentially the coup de grace. I mean, it's amazing the brilliance that surgeon has to have. So so you have that person, and they're in a car accident, and at the same time, in that same car, you have a garbage man who is in the car accident. And so both of them hit the windshield or hit the dashboard, and there's no doubt that they're damaged. You have a cardiothoracic surgeon who's over the last 7 years, his earnings are around $1.7 million a year, and you have the garbage man whose average earnings are around $50,000 to $70,000 a year. And so they both have the exact same amount of damage. I don't necessarily have to determine through my neurological eval or neuropsych eval if they deserve money. My job is to say, based on what you need to do as a skill set to do that job, how much has this impairment prevented them from being able to return to that job? And so what ends up happening is the cardiothoracic surgeon will never return to that job. And so he's a 33-year-old man, let's say 35, because it does take a little while to get to there. So he's a 35-year-old man or woman, and on average, they've got another 20 years to live. So we're talking about close to $30 million of revenue, gainful revenue that this gentleman has an opportunity to make. Then you have the garbage man. Their longevity is a little less because the wear and tear on their body is crazy. So you find that you don't find a lot of 60-year-old garbage men because it's so brutal on their body. But at the same time, there's not a great deal of intellectual or cognitive functioning necessary to be a garbage man. So even though they have the same degree of injury, their determination is that they qualify for disability also, but it's partial disability, and their determination from the assessment is that they don't get financial reimbursement. They don't get gainful employment reimbursement. They don't get disability per se. And so from a neurological capacity, we can look at a lot of what exactly do you need to see neurologically, absent or present, to then say that you have validity in what you see psychologically, especially around cognitive functioning. Because when we look at the neurological functioning, and it's really more neuropsychological, not neurological, neuropsychological functioning, when we look at those things, we see that there are some really, really specific skill sets that that you have to be able to then actually participate in a meaningful way with a psychological assessment. And so there are times, depending on the individual, there are times when my goal is actually to rule out what would interfere with there being a valid representation on all the other testing. And so one of the instruments we use is called the NIPSI, but it essentially is an instrument that can look at these specific factors: attention and executive functioning. Can they plan, organize, change, control behavior? Language. Do they understand what we're saying receptively, expressively? Can they say and communicate their thoughts? Memory and learning. How well do they take information in and encode the information? That's crucial. Memory is not just remembering, it's putting it in the file that's easy to retrieve. So they got to have memory, they have to have the capacity to learn from experience. Sensory motor, how well can they control their movements, not just hand movements, but really physical movements, eye movements. Social perception, how well do they understand? And this is part of that intelligence thing. A lot of you guys in the intelligence chapter talked about emotional intelligence and like sensory intelligence and interpersonal intelligence, and that is part of neuropsychological functioning. Can you empathize? If I showed you that TAT card and said, what's going on in this card, and it's the character looking over the bridge, and you said, oh, he's so happy there's balloons everywhere, I would say, well, there's really nothing in the picture that endorses that, but let's look at a little deeper. And I might say, tell me a little bit about the picture. They tell you, this is someone that's so sad they want to kill themselves. So I then say, tell me why they're sad. I'm looking for, can they make connections? This is one of the places that we see the autism, the pervasive developmental disabilities really struggle. But I'm trying to look at their capacity to understand the society around them, and then visuospatial processing. And some of this is the ability to literally look at your world, make sense of what you see, and then implement it in a useful way to problem solve. These things have to be in place for me to even be able to administer any of those other tests that I'm administering, because the reality is if there's any damage in any of these, it could impact the validity of any of the other testing. So when we look at neuro, we can look at this is a really quick little thingamajig, little handout that I give out to some of my students that just tries to break down, okay, what exactly are we looking for? And so you see, okay, so we've got frontal lobe. I take my assessments, and I'm a neuropsychologist. That's my field of expertise. But I take how they do on an IQ test, how they do on an MMPI, how they make sense of the Rorschach, the TAT, I do a mental status exam, all those things. And those things lend to giving the information about all those things we just talked about, psychological, cognitive, as well as neurological. And so I start seeing issues where they can't pay attention, that they have difficulties concentrating on visual discrimination, they have difficulties with sequential reasoning, they have difficulties inhibiting big word. And I'm going to show you the Stroop, which is a really kind of cool test. Really, really quick, but it's a red flag test. But just frontal lobe damage alone, you start seeing some of the things that they start manifesting. And from that, I then start looking at other instruments I'm going to do, or even some of the tests I usually do, like the WISC or the WAIS, the IQ test. It's going to give me insights into those types of deficits. I look at it on the other page, so I see parietal lobe, and again, all I'm trying to do is determine what kind of things manifest when you have these kinds of damage. And you can see, like with occipital, which is more vision, loss of the ability to recognize objects seen in other fields, difficulties having bilateral vision, difficulties processing color. So I told you that I was going to show you the Stroop real quick. So imagine this is what we're going to look at. Okay, so I put this in front of them, and I say, as quickly as possible, and I'm going to zoom in a little bit, as quickly as possible, I want you to read the word. Easy. Red, green, blue, green, red, green, no problem. Now I want you to tell me the color that the word is, not what the word is. Now you have to prevent that you are impulsive. Inhibition, big word, man. We see inhibition difficulties, impulsivity difficulties with most brain damage, especially around frontal lobe. But what happens is they start struggling with the transition between the visual and the processing of the word. So visually they see red, but the word says green. They have difficulties because those are two different parts of your brain in the right and left hemisphere. One is the analytical, visual, spatial, or visual recognition, discrimination recognition. And the other part is the learned behavior of reading a word that you know from familiarity of reading versus you know the word. And so it interferes with them. And so they go as fast as possible, and you see inhibition starts really, really having a hard time. So one of the goals with the neurological evaluation, the neuropsychological evaluation, is I want to take incongruencies. So when I do an IQ test, I get a pretty good idea of how capable someone is on all the cognitive, on all the neurological domains I showed you. I can determine how well they receptively understand what they hear. I can determine how effectively they communicate what they think. I can determine how well they can hold information in their brain, rearrange that information, and give it back to you in a predetermined way. I can make sure I can understand how well they can reason with language they hear by giving them two words like brave and strong, salt and water, pencil and pen, and I can see how well they reason that, as well as I can give them a vocabulary word and say, tell me what the word means, as well as I can give them riddles. I'm long, I've got cloth on the bottom, people hold my handle, and they use me to clean up messes. What am I? It's kind of a riddle. They got to fill in the blanks. I can use tests that I give them very visual things, and I say, tell me what's happening in this picture, tell me what happens next. That's sequential. There are so many things. Now, as I'm moving along, I'm seeing congruency, because most people are fairly congruent. Even in their pathology, they're fairly congruent. It's that whole trait theory thing. We tend to be who we are no matter where we're at. So anyways, because I can count on, from the instrument standardization, I can count on some consistent indicators of brain damage, of ADHD, of obsessive characteristics, of sequential reasoning, of aphasias and agnosias. I can see a lot of things that don't fit the congruency of the evaluation. When that happens, red flag goes up, and I pull out one of the neuropsych things, and I start investigating the why. There's something that's interfering with what I consider to be a normal course of progression for that individual. I'm individualizing it for that individual and saying the way they're performing, there's a glitch in one specific area that doesn't fit all their other performance, and it makes me segue to, we need to do some neurological stuff. We need to do some neuropsych. And it really is two different things. There are times when on an evaluation, I immediately refer someone for a CAT scan, an MRI, or even a SPECT scan. SPECTs are super cool, very exciting, not typical, but my God, are they diagnostically awesome. But anyways, different class. But from that, I see things that I go, that is indicative of occlusion, visual occlusion, auditory occlusion, which is not something I necessarily need to do a neuropsych on, but there's enough evidence to support that there might be something neurological, lesion, tumor, infarct, intracranial, lots of stuff that are red flags, and it can show up on an IQ test, it can show up on a Rorschach, because there's incongruencies. So the neuro testing will go much more in depth a little later, but it really is a place where, let me step back. I got into forensics because of my expertise in neurology, in neuropsych. And so I got called in, my first case, I got called in because there was an individual who had committed a crime, and it was not congruent with their personality. There was something that didn't fit. And so I started with a psychological evaluation, and from that psychological evaluation, I could tell that there were some incongruencies, that they had lots of attributes that suggested a great collaboration and socialization skills and social competence and sense of superiority in terms of their own skill base and self-efficacy. I mean, great stuff. But then there was this place where they just had this difficulty with inhibition, and I could kind of tell that the way that they were getting triggered, especially from the Rorschach, that last card I showed you, they were getting triggered. Like stuff was happening, and it was going, and the processing that was going on in their brain was going on faster than their conscious awareness of it, and they leaked, and they leaked, and they leaked. And this particular individual became almost explosive, like started tearing the room apart because they got triggered by something. Their amygdala started firing in a way that they didn't necessarily know how, because it stopped communicating with the hypothalamus and the hippocampus, which are kind of our arousal things. And so the amygdala and the hippocampus not communicating had this rage happening at the same time that the part of the brain that tells the brain how to resolve it wasn't involved. And so this person just lost it. There was no question, I could tell from that alone, that behavior, that there was amygdala difficulties and that there was probably demyelination, so that there wasn't communication between the arousal centers, the reticular formation, and the amygdala. And that came off of a test. I didn't have to see them. I didn't have to do brain imaging. I could tell just from the test that existed. Now, I didn't know why it happened, the etiology of it. That's where we then go do an MRI, a CAT scan, or a SPECT scan, because that's going to give us some insight into the what's it look like. Is it a demyelination? Is it strangulation? Is it neural death? Is there some lack of plasticity in the neural firing? Is there literally a lesion? Is there something going on? And sometimes it's drug induced, but I don't tend to do too much stuff that's related to drugs unless it happens by accident. But the neuro part of it, the neuropsych part of it, really lends credibility to why there's incongruence in the way that they perform on some of the other tests. So hopefully you enjoyed the lectures and all the other stuff that you're getting in the class. I'm really enjoying engaging with you guys, and I will talk to you soon.